Hello everybody, this is Tom Edrick, and this is Ultrasound of the Month for December 2013. Today we have a special guest, Dr. Andrew Miller, anesthesiologist and intensivist at the Brigham. We have no disclosures. We've changed the facts of this case to protect patient confidentiality. So, the patient you're taking care of today just had an ablation procedure for a cardiac dysrhythmia in the EP lab under general anesthesia. You're called to bedside because the patient now is hypotensive and tachycardic after this procedure, and he's not responding to fluid resuscitation. The patient also has chest discomfort. His previous medical history includes COPD, coronary artery disease, recent CHF episode attributed to dietary indiscretions. On exam, the patient is restless, has some JVD, mild expiratory wheezes, SATI 92 on room air, and has some diffuse chest discomfort. The EKG shows sinus tachycardia with the right bundle branch block, so your STs are hard to evaluate. The arterial line shows respiratory variations, and the urine output is low, only 30 milliliters in the last hour, even though they gave Lasix at the end of the procedure in the EP lab. Andy, you were the doctor called to the bedside. What was on your mind?
Well, at this point, I was considering calling a cardiologist, calling for a chest x-ray, and getting a transthoracic echo.
But while you were waiting, you were on your own. What was on your differential?
At this point, I was thinking about CHF again. He was volume overloaded during the procedure. Perhaps new myocardial ischemia, perhaps a pneumothorax with some tension physiology, or a COPD flare with some right ventricular strain. But then I remembered taking the focused cardiac ultrasound course recently and figured I would wheel in my own ultrasound machine before the cardiologist arrived.
So let's see what Andy was able to do with that echo probe before the cardiologist arrived. First, he places the probe on the chest in the parasternal long axis position with the index mark towards the right shoulder. That's the index mark, expecting to see the image as in this schematic. What does he see? Well, he sees a heart beating, but things look kind of unusual. Let's reduce the depth and look closer. So we have a heart beating. Not sure about the anatomy. Let's start by identifying some structures. So here's the pericardium, nice and echogenic, pointed out by this line. Now let's look for the myocardium, the epicardial border. That's there. So there's something in between epicardium and pericardium that doesn't belong, pointed out by this arrow. What does a normal parasternal long axis view look like? So here's our patient again. And on the right we have a normal patient. Here we see an echogenic pericardium. The heart is beating inside it. There doesn't seem to be anything separating the myocardium from this pericardium. Now Andy turns the probe 90 degrees to the patient's left, with the index marking pointed somewhere to the left side, expecting to see the nice round donut view of the LV. And on the right we see his image. So this is a left ventricle beating quite well, slightly empty, and once again the anatomy looks slightly unusual. Let's start again by identifying the pericardium and the epicardium. And so there is something in between, pointed to by this arrow. What does a normal parasternal short axis view look like? Here's our patient again, and here is a normal patient. Pericardium looks hyperechogenic. The heart inside is directly in contact with the pericardium. There's nothing in between. Finally, Andy does the apical forward chamber view, placing the probe at the point of maximal impulse with the nose of the probe pointed towards the patient's left side, expecting this kind of a view. And he sees a heart beating, and there is an echogenic rim of something that is surrounding the heart. So Andy, what was your diagnosis based on the physical exam and your focused cardiac ultrasound?
Well, the patient had developed a pericardial effusion that was causing cardiovascular compromise. I suspected cardiac tamponade at this point. This might have happened during the EP procedure when an intracardiac catheter perforated through the myocardium.
Wow. So let's take a look at other examples of pericardial effusion, since they all don't look the same. Here's a patient with a significant pericardial effusion. It's
humongous.
Humongous. Yes, the heart is practically floating inside this pericardial effusion. And in this parasternal long axis view, you can see that during diastole, the right ventricle actually collapses instead of expanding.
Look at that.
That's because the left ventricle is expanding at the cost of the right ventricle. Let's look at that same patient in the short axis view. How does that look? We've got the heart floating inside pericardial fluid.
Dramatic.
Now, the reason we see that this patient is affected by it is because the right ventricle is collapsing during diastole. There may be other patients you might encounter who have a big pericardial effusion like this, but the right ventricle doesn't collapse during diastole, and the patient doesn't have any symptoms of tamponade. So in this image, the patient is compromised by the pericardial effusion, but it's possible to have a large pericardial effusion without tamponade physiology. So let's talk about some of the pitfalls. One caveat is don't confuse pericardial and pleural effusions. On the schematic in the left, we'll identify anatomy first. Here's the RVOT, here's the left ventricle, here's the left atrium, the aorta, and the inferolateral wall, also called the posterior wall. Here's the epicardium, and here is the pericardium. So there's some fluid that's between the epicardium and the pericardium, and that is a small pericardial effusion.
Would this pericardial effusion cause compromise, Tom?
No, this is not large enough to really be expected to cause compromise.
How can we judge, just from looking, what we might think would cause cardiovascular compromise?
We can evaluate the right ventricle, but it's really beyond our scope. This is a patient in whom, based on just the size of the pericardial effusion, we can say it's highly unlikely to cause problems. However, we see a hypoechogenic area that is outside the pericardium, and that is by definition a pleural effusion. Incidentally, the round structure marked by the number 5 is the descending thoracic aorta. Let's take a look at another patient. Once again, parasternal long axis view, we see the left ventricle beating, the mitral valve, the aorta ascending, and we see the pericardium echogenic, and it's wrapping behind the heart and around the aorta. This is the descending thoracic aorta, and we can see that inside the pericardium there is a sliver, a very small pericardial effusion that's indenting the left atrium at times. Likewise, this is not likely to cause any cardiovascular compromise at all. And just like the patient on the left, we have this hypoechogenic area that is outside the pericardium, and that is actually a pleural effusion. That's quite common. So we just spoke about one big caveat. Not all pericardial effusions cause tamponade physiology. Slowly accumulating effusions can cause the pericardium to enlarge gradually without causing significant hemodynamic compromise. So determining whether an effusion causes hemodynamic compromise is complicated, and it's outside the scope of focused cardiac ultrasound per the guidelines of the American Society of Echocardiography. But if your patient is hypotensive and tachycardic and there is an unexpected big pericardial effusion, then you probably have tamponade physiology. So you should call for a stat echo by cardiology and call for somebody who can help you possibly place a pericardial drain. So Andy, how did this case of yours end?
The cardiologist did arrive, saw my echo, repeated his own echo, and agreed that the patient had cardiac tamponade. The patient was returned stat to the cath lab, a pericardial drain was placed, and the patient stabilized.
Wow, Andy, that was quite a case. Thank you very much for presenting it.
Thank you, Tom, and thank you for the training. It turns out cardiac ultrasound was indeed a great way to diagnose this patient's problem.
Thank you. So this concludes our ultrasound of the month. Please tune in next month. Bye-bye.